I'm the sort of lead for elective cancer and diagnostics at the ICB. We've got so many people in the meeting. Obviously, we're not going to go around and introduce ourselves, but most importantly, we've got the national GIRFT team here, led by Tim Briggs, and we've also got some regional representatives and other GIRFT representatives from the country or West Midlands who are kind of looking in and observing. I would just say if people are pitching in, if they can introduce themselves when they do, that would be helpful. We've got a really quite packed agenda, and notably we've got quite tight timeframes. So just to say, and by way of housekeeping at the beginning, each of the specialties that we're going to go through only has really 8 minutes to present their kind of slides. So please bear that in mind, and to a certain extent, assume the slides are taken as read, and it's drawing out the important factors that you want the national and regional teams to know about. Same goes for the outpatients and theatre productivity, which are actually only 4 minutes. So let's try and keep things to time. So without further ado, in terms of the successes, etc., that we've got across the board, Tim's already mentioned that we've made some really, really good progress. But I think that, we've got very embedded specialty meetings taking place across the specialties. We would say that we can probably expand these and in some cases make them have more teeth, but they are making really, really good impact. We are at the moment doing very well in driving down our 52-week waiting times. And the improvement in figures has been huge, and actually a big improvement again since November 24, and the numbers are dropping dramatically. In terms of collaboration and learning, well, we've done very well with our mutual aid and the foundation group. Now that all the trusts or both our trusts are part of the foundation group, seeing the sort of chance for cross-foundation group working and cross-ICS working has become the norm, and actually the resistance to it is diminishing all the time, and so that's really positive. And finally, in building on our clinically led and data-driven GIRFT approach, we are at the moment having good collaborative conversations across the ICS around how we should be looking towards building a sustainable future. A really good event attended by many people yesterday, and certainly we are working very much on how we make those big changes that are going to make a difference in the future. We all know the challenges, they're not new. They are very much the same challenges of pressure within the system in terms of capacity, financial pressures, and the demand on our services. So we won't dwell on those anymore, but we'll go through them in the meeting. If we can go to the next slide, we're going to go to outpatient transformation. And particularly what we're trying to do is to involve clinicians or operational staff from the trusts, supported by the ICB team in presentation of each of these slides. So I'm pleased that we've got trust members to sort of speak to this. Now, Andrew and Amanda were going to talk to this, supported by Kirsty. So Andrew or Amanda, do you want to pitch in from the start around the outpatient transformation?
Yeah, hi everybody, Amanda Moore from Worcester Acute. I'll jump in before Andrew to get my couple of minutes. Really pleased how the work has gone, especially with using obviously our GIRFT handbooks, etc., and the work that's been going on in the trust. And as you can see straight away, our PIFU rate has been slowly climbing, and with good news, we're on target to hit 5.5% by the end of January, so that's really good news. And already some of our specialties getting more than the 85th percentile for PIFU, so that's great news. We've done a lot of work around DNAs, massive action plan back in the summer. We contacted over 2,500 DNAs from the month of June. The action plan has developed from there, and we've seen significant work and reduction with our DNAs, and that continues. I'm really pleased with that work. Remote consultations, we've talked about this as a group to try and to get the benefit from that. Our clinicians are not openly bought into so much the video consultations, but very much bought into telephones. That's working well. Andrew, do you want to come in?
Yeah, absolutely. I'll just quickly go through these, the real key indicators for us. PIFU, we're going to expect to be above 5% once we've had the Maxims upgrade. We're not near 5% at the moment for DNAs. A real focus continues to be on that, and just saying that at the end there, by reviewing some learning from Worcester there, especially looking at those patients with a higher propensity to DNA. The 46% target outpatient utilisation, we've had an increase in 4 percentage points from the start of the year up to now, which has been really, really good to see. We're aiming for 10% decile performance next year to be at hopefully 50% for the end of 25-26. Other real key focus area, clinic templates. We're really focusing on CNS templates and job planning at the moment, and we're hoping to see some real gains there. So that's all I've got to say for Y Valley.
Can I ask a question of you both, actually? So can I ask what the PIFU rate is for orthopaedics across both sites?
We're averaging around 14% in the last 3 or 4 months there. I can just confirm that, Tim, for you.
Okay.
I've got it in front of me, Tim. It's 11.8 at Worcester and 12.1 at Y Valley based on latest model hospital data. Andrews may have been later than that.
Okay, so that's going in the right direction. It should be around 15 or 16%. So when we look at the target, what I don't want people to say, well, we're all right because we've hit that target. Given where we are, what we've got to do in both the outpatient and the day case inpatient space, we've got to maximize this methodology. So I want to go way above 4%. There'll be some specialties that do that move that more quickly. And I think in terms of orthopedics where I am, I'm at 18% at the moment. So what we'd like to see is a real drive in the specialties that we can absolutely maximize that to get that going. Because if you said to me around the country what the issues, orthopedics, ophthalmology, ENT, those are for me the really big issue. So let's really drive PIFU if we can.
Okay. Is it okay if we move past outpatient transformation and on to theatre productivity?
Yeah, so Angus, can I just ask one other thing? So have we standardised consultant templates as per the 16 handbooks in each of the specialties and then shared them across the 2 trusts, because you are now one system, to standardise? So for instance, in orthopaedics, Andrew, what are we doing in orthopedics in Y Valley? How many patients are they seeing in a consultant 4-hour clinic, and what we're doing at Worcester Acute? Can anybody tell me that, just a matter of interest?
I haven't got the numbers to hand, but I know we have been working on this together with Y Valley to make sure that we're matching those templates. We use a system called Pythia at Worcester, which is something that the clinicians with the management teams update every year to look at our position on our clinic templates, and all the job plans are obviously being reviewed around making the most of that job plan for outpatients and theatre sessions.
Andrew?
Yeah, we have a weekly transformation meeting with Worcester as well for outpatients. It's work in progress, Tim. We will be hopefully finalising that over the next month or 2.
Okay, so again, Angus, just going back to that, we've known about this for a while, about the further faster. So it's not new news. It's again the pace at which we do this. We're going into 25-26. It's going to be a tough old year. We've got to get ahead of the game. 18 weeks. We know what the productivity gain is. We can't delay this, guys. We need to do this ASAP. So Angus, it's just the pace we're doing this in outpatients is some really big wins for us when you look at all the variation. And of course, with the MSK community come on stream, that's also going to make a big difference. So I do want these templates. And when we talked about neurology, beginning with an N, Again, what's the standardization clinic templates there across both sites, if you have them on both sites? Because again, wherever we've done this sort of this piece of work, we've seen a productivity gain of about 20%.
Okay. And so I hope all the operational teams and the clinical leaders within each of the organisations that are on this call are thinking about that, because outpatients affects everybody. And, you know, just take that challenge. Thank you, Tim. Going on to the theatre. So from theatre productivity, we've got Julie Briggs from Worcester and also Jonathan Bolter from Wye Valley. And again, the slides have got a lot of information. Julie, Jonathan, who'd like to come in first?
Yeah, happy to go first from a Wye Valley perspective. So in the quick 2 minutes, just to pull out some of the key points on this slide. So to measure the start progress, I think it's probably best described as we've been on a pretty big journey at Wye Valley over the last 12 to 18 months from a theatre utilisation perspective. It's been everything we do has been bread and butter, ingrained in everything. We have obviously opened up the elective surgical hub in the summer, which has been a great asset to us. And not only has it given us what a hub should give us, it's actually enabled us to unlock productivity benefits across the rest of our theatre estate in main theatres as well. So just picking out utilisation, so December just gone, utilisation was 80.9. January is now in at 80.1. So that marks 3 out of the last 5 months, really, since we got to grips, since the hub opened, with 3 out of those 5 months have had 80% or above in terms of utilisation. That's in the context of some significant medical workforce and anaesthetic issues that we've been navigating. But just to highlight that kind of progress in that journey, the first 6 months of 2024, we averaged at 76%. The second half of the year was 79.7%. Internally, we've set ourselves some targets with some 4 key specialties, and that was getting utilisation to 80% or above in ENT, ophthalmology, gynae and general surgery by the end of January. December's utilisation for those specialties was really favourable. So ENT achieved 80.4% against their 6-month rolling average of 74. Ophthalmology 80.7 against 6 months of 74. General surgery 91.3, which is a big movement against their 6-month rolling average of 78, and gynae at 79.1. So just missing out at 80% there, but looking favourable as we went into January. We've really been focusing on average cases per list, and that productivity increase there. So post September, we've seen an 18.75% increase in the number of cases per list across all of our theatres, so main theatres, but also the hub. And that's going to reflect it in our activity numbers and our throughput throughout the course of the year. So in 2023, our average number of cases was 688 a month. In 2024, that was 825. And October, we had a record month of tipping over 1,000 patients treated through our theatres estate, which for an organisation of our size, we were really pleased and just mark that change. I mentioned the hub at the start. That's been a really good asset. It's been a key driver in the productivity improvements, not just in the hub, but across our main theatres estate as well. And from just looking at the hub in its own right, the latest Midlands GIRFT high volume data pack for December shows us as top performing for hub utilisation of those 16 Midlands trusts for cap touch time utilisation. And also just to note, in terms of what the hub has also delivered, in terms of being able to continue with elective activity as we've hit winter months. As all organisations, we had a really tough couple of weeks in January. Those first 2 weeks, critical incidents, we only cancelled a handful of patients. And when we just did a quick bit of modelling, we reckon if we didn't have that hub, so if we were back where we were this time last year, we'd have cancelled somewhere in the region of 35% more elective patients. So the hub really showing its value there. And then finally, just on the day case numbers, so our latest day case data shows 84% in the second highest quartile nationally. So to summarise in 15 seconds, we've made a lot of progress from last year, still much more to do, particularly around embedding more 6-day working, continue review of the BADS data and challenging ourselves, continue around what more we can do high volume wise. and just continue with our trial of long afternoon sessions into the evenings in the hub, which we started this month.
Jonathan, can I ask 2 questions? One is your length of stay for hip and knee replacement still seems not where I need it to be. So what about take case arthroplasty? When or what's the plan for starting that?
Yeah, so we've got a specific project involving our anaesthetist team and our orthopods that has started to really embed some of the stuff that we need to do to bring that down. We do have orthopod surgeons on the call for any specific questions around the day case bit, but we are really focused on moving that in the right direction across the multidisciplinary teams.
Okay, so Jonathan, have people been to see Devon or Heatherwood, and just because we just don't need to reinvent that, we just need to implement it like they've done in Nottingham, and the results are fantastic. And are we working across both trusts as in the orthopedics as a joined up? Because I hear maybe not. Tell me about that.
I think with working across the organisations, there's always more we can do. We've got the ability through all of these ICB-led meetings to do that. I suppose it's a journey, isn't it, in terms of that engagement and moving it forward?
Well, we can't be on a journey anymore because we're on a burning platform. So what I want to see from this is a real joined up approach. And I speak as an orthopaedic surgeon. It's the only way. And let's put the patients at the middle of that. And that would be great. So that'd be one of the things. Can I just, how many HVLC cataract lists are you doing a week through your hub? And how many cataracts are you doing on a list?
So we've got the cataract suite in the hub, which we're allocated all day, every day. We are in the region of 8 to 10 on a list, which is up on where we were significantly this time last year, but still more to do in terms of embedding across all of our surgeons. Okay, so I don't know if everybody knows how much we spend in your ICB in the independent sector a year, but if I go to Cheshire Merseyside, where I was yesterday, 166 million. Where I was just come from earlier this morning, it was 66 million, and quite a lot of that is orthopedics and cataracts. If we're going to survive going forward, we need to bring all that work back into the NHS to do it in-house and consumer and smoke. So again, as you say, more to do, but really to do it at pace. So again, we can follow that up, but maximize the number we're doing. 8 to 10 is fine. I'm really happy with that. Question is, how many lists a week are you doing that? Because we can help with single point of access, doing the work. And I hear that the waiting times are down to 10 weeks, which for the sweet spot is brilliant. So we're on a good journey. We just really need to hammer that home. Otherwise, some great stuff. Delighted about your hub, by the way.
Completely agree. And I think that that challenge isn't to Jonathan, that's to both organisations and to all the clinical teams, because we know how important the clinicians are in optimising this flow and bringing stuff back in-house, which is what we mentioned in our meetings. Fiona.
Yeah, thanks, Angus. Jonathan, I just wondered if we can agree in action, and hi, nice to meet you. I know we've been exchanging emails about the mock visit. I've got my regional orthopaedic clinical lead on the call, Pandy, and I think we tried to reach out to the orthopaedic team at Wye Valley just to offer some support around length of stay and day case. So if we can agree in action that we can make that happen and see what support we can give you, understand you've got your own internal improvement project, but actually we're here to help. So if we can just have a conversation offline, that'd be really good.
Yeah, value all input and support. Yeah, and our
Lovely.
new SOP pathway starts on the 17th of March for arthroplasty length of stay. Lovely, thank you.
We may revisit some of that. Now, I'm going to come to Julie, but bear in mind that every minute we're taking here, the 8 minutes that specialties were having is reducing dramatically to 7, then 6. So, Julie, salient points, please, from your side of the table. Is Julie not there? That's fine. So, I mean, taken as read down the Worcester side of things, we can read that slide there. I think the challenges that you will be putting to us, Tim, would be the same as pretty much.
Yeah.
So I'm going to, if you don't mind, in the interest of time, move on to the gynecology side of things. Gynae, now we've very fortunate to have our ICB lead, Kirsty, here, but also we've got the clinical leads, Alex and Celia. Do you want to start Kirsty, do you want to say anything, or should we just let Alex start?
I'll make a start, Angus, and then
Go on.
Alex and Sally are going to chip in as we go through. So from a further faster perspective, in terms of our waiting times, we've seen a really significant reduction in our 52-week waits for both organisations, 92% reduction in Worcester and a 61% reduction in Wye Valley between July and October of 23-24. And you can see the trend line there moving downwards for all of our long waits. From a further faster perspective, in terms of outpatients, we perform relatively well for gynae. We've got really good advice and guidance uptake with a embedded common conditions document outlining our referral pathways across a number of condition areas. We have improved PIFO activity, again performing above the 85th percentile. Really good progress with PIFO and continuing to maximise that opportunity, both with outpatients but also following surgery. In terms of our right place, right procedure activity, our outpatient hysteroscopy remains above our peer benchmark. We recognise there is still some work to do around improving the rate there. Given the sort of campaigns around painful hysteroscopy, we are looking at whether we can use Penthrox moving forward to help increase that rate there in outpatients. Colposcopy, we remain above national benchmark. And we know that we've got an area of focus around our minimal access rate for hysterectomy. We have seen an improvement between Q1 and Q2, Worcester acute at 89.1%, and a really good increase from Wye Valley from pre-COVID at 8.6 to now 51.8. There's been a lot of work there around body and system training with minimal access rate, and the introduction of the robotic assisted surgery, plus the establishment of the elective surgical hub. So continuing to reduce that variation between providers, which is positive. Can I have the next slide, please, Emily? Thank you. In terms of our theatre productivity and utilisation, really good performance around number of cases per 4-hour session, fluctuating between 2.2 and 2.6 above national benchmark. We are looking at operating times and mean operating times within Wye Valley, and then opportunity for sharing that learning across to Worcester. Touch time utilisation, 80.5% as a system, really good from Worcester at 87.3. That's the November data. Latest position at Wye Valley, the November position there is at 69, but we have seen an increase over December and January to 80%.
Kirsty, can I ask a question there? Now that is a massive variation, all right? And no one should be below 70% now. So that is an unacceptable position. So what are you going to do following this call to really ramp that up? Because whatever they're doing at Worcester Acute, they are really smashing out the park. So I need that learning to be cascaded ASAP, because 69.7% is just not acceptable.
Yeah, they've already increased to the 80%, and they've got their weekly reviews, look back theatre reviews. They've got individual conversations going on with clinicians. The elective surgical hub's obviously helping with that. The cases per list, the mean operating times, all in place. I think Rose has got a hand up to respond on that as well.
Rose and Jonathan may have the updated position, because a lot of work's been going into this, Tim.
Good.
Yeah, I see Jonathan's hands up. So yeah, we've been doing a lot of work on this on a monthly basis. I think that position was a one-off. I think prior to that, we were nearly hitting the 80%. We've been teetering along at about 78, 79. We dipped for a month, and then we've driven it again. We've got monthly theatre look-back meetings whereby we look at the activity by consultant and understand where we've reduced the productivity, and then we feed back to every consultant and look at what we need to do to support them to improve their productivity.
Brilliant.
Thanks, Rosemary. So yeah, Jonathan was going to say the same thing, I think. So I'll move on. Carry on, Kirsty.
In terms of our length of stay, top performing in the country from Worcester, 95.2% for vaginal hysterectomy. Again, some variation between providers, but starting to close that gap and really seeing an improvement over in Wye Valley. Key actions in place, early TWOC, implementing dedicated senior clinician review on gynae wards. Some challenge around access into gynae beds, so having that additional middle grade and senior clinician review will help prompt those earlier ward rounds with the change in the TWOC practice as well. So we know that we've got some variation there and continuing to close that gap. Also sharing that learning from Worcester in terms of the SOPs for same day discharge, and we've got the matron from Worcester linking in with the team in Wye Valley to look at virtual ward rounds with the nursing team from the gynae assessment unit to help with same day discharge. Next slide, please, Emily. Just a quick overview of where we're performing in line or better than our peers and national median. All of the areas in green we've talked through. The points in red, I think the one that sticks out the most at the moment is the length of stay, which we know we've got some key actions around and we're working on. The other areas, we're doing some sort of data quality review. We just want to check that our emergency readmission rate is actually true and a reflection of those rates. We think it might be wrapped up in some of the gynae assessment areas and therefore reattendances rather than readmissions. Outpatient sort of non-face-to-face, challenging in a gynae specialty, but using where appropriate. And outpatient rate for cystoscopy, we've had a change in coding, so we should see that data improve and filter through as we move forward. I think that's it for my gynae slides, but we'll defer to the, no, one more. Success to date, we've done a lot of work around implementing MVA, so moving from CPOD theatre to an outpatient setting for management of miscarriage. We've established a one-stop minor procedures clinic. There's a lot of work going on around the Women's Health Hub, and important to mention because we're using and engaging with the same teams and the same clinicians to set up the Women's Health Hub. But some really good progress there around a menopause pilot. We've redesigned that pathway and had really good feedback from patients. We've just looked at redesigning the prolapse management pathway, so shifting from hospital to community, and we've changed some of the commissioning arrangements for how we fit coils. We've looked at our EMIS templates, our common conditions document, and we are just about to implement the postmenopausal bleeding pathway with a change. I'm going to embarrass Alex because she's become our clinical director for the regional GIRFT lead, which is really positive and helps us out locally. And then in terms of what's next, obviously what we've talked through with the variation between the two providers, understanding emergency readmission rates to see if they're true, continuing to progress the Women's Health Hub and see how we can replicate the model there and move that across other conditions and other specialties, and then implementing the postmenopausal bleeding pathway, looking at PIFU and maximising all of those opportunities there, and looking at any other GIRFT metrics where we think we've got an opportunity.
Brilliant. Kirsty, you're doing some really good work. I want to know just a little bit how you get shared learning across. And if you look at going back to your minimal access rate for patients under 50 for hysterectomy for benign conditions, as a system, you are improving rapidly. If you look at my latest data, Worcester has the highest rate in the country. It's number one against a top decile rate of 71.7, which is unbelievably fantastic. Wye Valley, though, is at 51.8. Now, how do we get the shared learning and implementation there to make sure that everybody is getting the best out of that sort of success from the one trust to cascade into the other?
Can I come in there, Kirsty?
Yeah, of course.
Yeah. I mean, I've been very involved in this, as you know, Dave Richmond may have told you. We've been very involved with how we implement this same day discharge. There is either we parachute in and try and do stuff for Wye Valley, or actually we had that conversation a few years ago and said, actually, we can learn from you, and actually the improvement from the standing start that Wye Valley had on not even being able to offer laparoscopic hysterectomy to now doing so well, the day case part to it is the next step. And I think that the Gynae Forum, led by Kirsty, but with very good clinical and operational input, is absolutely the way to take this forward. And I think the progress that's being made won't stop. It's continuing. And I hope that Wye Valley feel very supported by Worcester to make the differences, short of the Worcester team parachuting in and doing the work for them. It's actually about just getting the right practices embedded. And I think that Wye Valley's improvement is far greater than Worcester's improvement, but Worcester started in a much better place.
Okay, thanks.
Ehab?
Yeah, thank you very much. So I just wanted to come here just to reassure you that we started setting up a stop for the same day discharge. We looked into the stop from Worcester, and as you can see, the number of laparoscopic hysterectomies and robotic hysterectomies is increasing, and we are in the process of organizing a team for patient education regarding the same day discharge in collaboration with an anesthetic team, and hopefully that will start soon.
Wonderful, thank you, Ihab.
Thank you.
So, Tim, it's okay, I'm going to move on to orthopedics. We've already had some conversation about it, and I'm terrible chairing, we're well behind, but from the orthopedic teams, Matt, are you leading off, or David or Charlie, are you taking it from the start?
I'll give the overview and invite the clinical leads to come in and comment and add context where necessary.
Very happy with that.
Okay. So yeah, firstly, just to give a bit of an overview on waiting times at Wye Valley, significant reduction in patients waiting more than 65 weeks and aiming for 0 by February. Ongoing outsourcing to achieve the 0 52-week waiters by March 25. At Worcester, working towards 52 weeks by end of March 25, with currently 0 65-week breach patients, with a focus on dating inpatient waiting lists and reducing undated new referrals. We have talked about the PIFU rate, but the figures are there for you to have a look at. Right procedure, right place. Wye Valley dedicated MOP sessions for hand procedures started in January, with increase in the volume of injections taking place in outpatient settings. Worcestershire Acute moving hand list from the Alex to Kidderminster Treatment Centre, and some additional construction work is going on to increase the ability to do this. And all ACL procedures are being booked through their day case unit. Before we move on, the clinical leads, do you want to add any context or comments?
Matt, while they're doing that, can I just ask one question? If you go back the slide, so you've now got your hub, which is doing orthopedics. So why are you outsourcing arthroplasty when you've got a lovely new hub which you should be using 6 days a week, or maybe you are using 6 days a week?
David was probably best placed to answer that.
Yeah, so the elective surgical hub is a cataract suite and 2 theatres, and currently orthopedics has access to that Mondays and Thursdays.
Okay, so just again, Angus, just going back to, I don't know how much you're spending as an ICB out in the IS sector, but one of the things about these surgical hubs was to maximise and return a lot of work from the IS to the NHS, which is important. And if you look at Wye Valley on that slide and Worcester Acute appears to be 52 weeks by March. Wye Valley is struggling to do that without outsourcing. Health inequalities, sharing the PTL. Have we thought about doing that, Angus, about sharing the PTL around arthroplasty to make sure there's no health inequalities? We help each other out, because the more we do in-house, the more that we sustain our services.
And I mean, David, do you have any comment to make on that from a Wye Valley point of view? Or Charlie, what are the blockers to bringing more work back in-house or sharing the PTL?
So if I can come in on that one, there are no significant blockers in terms of sharing the PTL. That would make perfect sense. But I think you've probably got issues with regards to capacity at both sites. So I think the Alex is probably at capacity with regards to elective orthopedics, and certainly Wye Valley is at capacity with regards to elective orthopedics, although we are trying to increase capacity for elective orthopedics at the Wye Valley. So there is no particular difficulties about sharing the PTL on a notional basis, but it's about looking at the capacity of both sectors.
Okay, and David, if you got your length of stay down to 1.5 to 2 days, so down in Nightingale, 63% of patients with hip and knee arthroplasty go home as a day case, 93% or 94% within 23 hours. That would allow you to increase your throughput and your capacity through the same bed base, right?
Same bed base. The bed base isn't the issue for elective orthopedics. It's the theatre capacity.
Okay. What about weekend? What about weekend working?
We're not currently doing that. No.
So we've got to make some choices here, right? If
Correct,
we leak all this, Monday to the independent sector, right, we're all going to go bust. So you've got the asset, right, and you've got this brand new hub. You've got to use it 6 or even 7 days a week to get on top of this, so we don't move all this stuff out to the independent sector. Okay, Jade.
Yeah, that's part of the plan going into 25-26, is that if we can reduce our tail, our long waits, and we're on track to do that by the end of March, then next financial year, all that work out to the independent sector will be switched off.
Brilliant. Thanks, Jade. That's what I was looking for. Excellent.
I've been sitting still for so long, all the lights have gone off. I'm going to have to move around to make the lights come back on. Right. Okay, carrying on then, Matt.
Yeah, no problem. So theatre productivity and utilisation, we're currently fluctuating between 2.6 and 1.7 for our 4-hour list, with a system medium of 1.9. In terms of theatre utilisation, we're currently at 87.7%, averaging 90.2 in Q2, and that translates at 87.1 at Worcestershire Acute and 95.6 at Wye Valley. And we've got a system median at 81.9%. At Wye Valley, consultant-led lists achieving 85% utilisation. Middle grades lists are improving. At Worcestershire Acute, they have weekly operations meetings, which we've talked about, to discuss theatre utilisation and ensure full lists. Again, before we move on, is there any comments from clinical leads or any questions, Tim?
Yeah, Matthew, if you're looking at the middle grade list, vary by clinician, but are improving, given the fact you're moving a lot of work outside the independent sector, we need to knock this on the head quickly and absolutely maximise all our assets. We can't have lists not being thoroughly used, all right? So again, 85%, we want that for all lists.
Okay, so length of stay. So you'll see some small improvements made to length of stay for total knee and total hip, and although we acknowledge that there's still more to do, and the clinical leads will be able to share the work that's going on around that. So we're currently, we've had a reduction of 0.3 days since Q2. So we're seeing 3.3 days for hip at the moment, and that's that averages 3.3 at Wye Valley and 3.2 at Worcestershire Acute. We're seeing 3.4 days for knees, which is a reduction of 0.4 days since Q2. And that translates at 3.6 days at Wye Valley and 3.2 at Worcestershire Acute. And fractured NOF, we're at 16 days, which has increased by 2.4 days since Q2. But just to note on this, that the Worcestershire data doesn't include the full pathway, so it only includes the time spent in the acute sector. So that translates at, so it's 19.3 days at Wye Valley and 14.2 days, but as I mentioned, it doesn't include the full pathway at Worcestershire Acute.
Now, can I just bring in Mr. Pandy?
You're
The length of stay remains pretty high, although there has been improvement. And we, the Midlands team, have been trying to get in touch with the Wye Valley to see if we can help in some way. And one of the things we can do is to either visit you guys with a team or get a team from Wye Valley to Leicester or Nottingham or some of the other areas who are in the same boat as you are now and have improved. So that'll be a good thing to just to see what people have done and share the good practice to improve this, because the length of stay for knees and hips over 3 days is still a bit unacceptable. So we've been trying to see if we can help out by visiting some centers which have done a lot of work on it already, and we can learn from each other.
Okay, so Charlie.
Yeah, Charlie Docker, Clinical Director at Worcester Acute. Yeah, so in terms of day case for hip and knee, I mean, we did the visit down to Exeter with some of our colleagues from Wye Valley at the same time. And, you know, it's very impressive, the work that they're doing at the unit there. And what we took from that really is that to aim for, you know, every patient potentially to be a day case patient. I think part of the work that we can bring back in from the independent sector includes a lot of the patients who are the ideal candidates for that. They're also the ideal candidates to be able to reduce anaesthetic time and surgical time and make the 4 joints per list, you know, improve even on that metric. So, you know, it is key to getting those back in. In terms of what we've done, we have got the enhanced recovery protocol, including the anaesthetic protocol at Worcestershire Acute. We've increased the numbers of day case patients, but it's still not a routine that's day case. The resources that we've got, we're aiming to make sure that we maximise the day 1 discharges, so next day discharges. We're also doing a project looking at staggered admissions for the last patient on the list, which obviously, you know, would potentially reduce the amount of time that they're in the hospital, but also improve patient experience, hopefully. So there's a number of things that we're doing at the moment. Ward 16, we're looking at putting trolleys into the one bay at least to start with, to kind of replicate that kind of experience from Exeter and have that kind of the psychological kind of change that instills as well with patients that they are just in for a day case. Biggest resource that we're lacking probably is still physiotherapy, just to maximise the evening ability to keep mobilising the patients to get them home on day 0. But there's work going on with that.
Okay, I mean, everyone's hearing the challenge, and it's one which is being echoed by national GIRFT, regional GIRFT. Chizo, do you want to come in?
Yes, I was going to bring Mahmood in actually, because he has been working hard on this, and we're just about to launch, or we have signed off on the improvement plan. Mahmood, did you want to elaborate a bit more?
Yeah, we have actually, with the help of a GIRFT outside team, started to look at the length of stay, and it is completed. We look at the anesthesia and pre-op, post-op, and analgesia, physiotherapy in the community. All that pathways are complete, and final sign-off is on the 12th of March. And hopefully from the 17th of March, we're going to implement the new pathway, and then going to audit it every 4 weeks to see what are the issues which are coming across if a patient doesn't complete less than 2.7 days.
Mahmood, has that been shared across both trusts? So you're at Wye Valley. Has it been shared across Worcester Acute?
It will be a big task. First, we are going to implement it here in the Wye Valley, because there was a lot of stakeholders. So once we started, we were more than happy to pass it on to our Worcester colleagues to have a look at that.
So can I just ask again, Angus, the takeaway here and the action is that needs spreading now. You can't wait. We've got to get it up and running, going, because there's significant increased capacity, especially if you use your assets at weekends, to implement this. And it's not difficult. It's been done elsewhere. You just copy and paste what others have done. All right. It doesn't need huge number of stakeholders. It works. This is what we're going to do. Let's get on and do it. That'd be great. Thank you.
I hope everybody in the trusts has heard that. I have heard it, certainly, and agree. Right, so moving on, in the interest of time, we've got to just skip through this very quickly, please, Matt, because we need to get on to the EMT as soon as we can.
Yeah, that's fine. I'm not going to go through this. You'll notice that we've already mentioned the areas which are performing red, and if we skip over to the next slide, you'll see that they're replicated in our plans for the forthcoming year. Just to give a bit of an overview on successes with what we've done to date and what's next. So Wye Valley launched their fracture clinic, so that went live in January, delivered their perfect fortnight, and taken the learning from that. They've implemented a joint school patient education sessions to support those patients on the list, getting them ready for surgery. You've just heard from Mahmood there about the project we could establish to look at length of stay. So that's in process. Worcestershire Acute successfully delivered day case joint surgeries, delivered a number of so we delivered super clinics. Length of stay task and finish groups have established with interventions on improved communications, and Charlie mentioned it there about work doing to improve the physio coverage to aid discharge later on in the day. System wide, so we developed the ISP orthopedic service specification, improve MSK triage process for patients in the north of the north of Worcestershire, and secured funding to support provision of 24/7 MRI scanning for suspect cauda equina. And then moving on, you won't be surprised to see continued focus on length of stay for knees, hips, and fractured neck of femur. Deep dive into the readmission data and implementation as to for interventions as required, and a revised spinal pathway to include both red and amber flags. Review the MSK model of delivery and integration with the acute services, improved optimization and enhanced recovery pathways, working with the APOM work stream in doing that, continued engagement with GIRFT further faster. So that's my presentation. Before we move on, is there anything that the clinical leads just want to add to that before we go?
Thank you very much indeed, Matt. Katie's got a question.
It's just a really quick one because I'm conscious of the time. I noticed there it's got my pre-op plus across both trusts. Has that been signed off financially, etc., across both trusts now?
No,
I know it had at Worcester.
Yeah, it has at Worcester, but it has to go into next year's financial planning for Wye Valley. This has been particularly sort of flagged because obviously it ties in very much with the APOM work that's going on, which we are also funding for that, as you know, nationally has gone, but we're trying to support it going forward. I know that the senior team at Wye Valley know how much we want to get my pre-op, but it comes into the financial priorities for next year.
No, thank you. Thanks.
Okay, so thank you very much indeed, Matt and the orthopaedic teams. Moving to ENT, and Amy, are we sticking with you leading, or are Steve and Simon going to do that?
Me in the first instance, thank you, Angus. And then I've got Mr. Lewis and actually not Mr. Prowse with me today, but Mr. Al Zahid from Wye Valley, just to clarify.
Who's our GIRFT lead, so wonderful to have you here, Safe. Thank you.
Brilliant. So just to provide a little bit of a high-level overview, so although we are seeing a large number of patients waiting, that percentage has increased by 9%. It's worth recognising that this is against a 20% increase in demand, so a really high level of demand coming into these services. And we still have a lot of work to do around our long waiters in ENT, and you'll see some of that in the plans on the following slides. Some positive work in terms of our outpatient work, so advice and guidance being utilised, but perhaps more so at Worcester, and some work to do at Wye Valley. PIFU steadily increasing at both sites, just shy of the national benchmark at the moment. So some more work to do there, so some small steps in the right direction, but more to do. Across our right procedure, right place, we've reviewed where these procedures sit across our organisations, and I'm pleased to say that the vast majority are meeting those recommendations in terms of where procedures are carried out, particularly those high volume procedures. There is a little bit more to do in a few small volume areas that might have some gains as well. If I can have the next slide, please. Thank you. So really positive story around theatre productivity and utilisation, so above national benchmark at both sites for our theatre cases per 4 hours, and our capped elective theatre utilisation at 76.8%, so above peer and national at Wye Valley and just shy at Worcester. In terms of our length of stay and admissions, the day case rate for adult tonsillectomy is up there around the national benchmark for Worcester and just shy at Wye Valley. And then in terms of our adult readmissions for tonsillectomy, we're performing better than peer and national benchmark. although there have been huge improvements in our day case rate for child tonsillectomy, there's more that we could do here by working more closely with our anaesthetist around that new ENT UK guidance around obstructive sleep apnea, and that work is ongoing. There is some challenge around the day case rate in paediatric tonsillectomy at Wye Valley, which is due to children travelling long distances, which is probably skewing some of this data, but perhaps more we could do in terms of looking at when our clinics are structured. In terms of the BADS ENT, exceeding that local ambition of 85%, but just shy of the national and peer benchmark. And then we know this is a slightly unusual metric for ENT, the last one here around ENT admission with no procedure at 58%, but we are still exceeding the peer and national benchmark at Worcester, but not at Wye Valley. If I could have the next slide, please. So I won't dwell on this one too much, but just to say that we are planning some more detailed work around pinching with pride the dashboard that has been developed for gynae around the HVLC procedures in ENT, but also just to pick up on the data anomaly that I know Kirsty's already had mentioned around some of those emergency readmission rates. So we've got a little bit more work to do in unpicking the data there. And the final slide, thank you. So we have completed a review of the community ENT pathways, and we think that the tinnitus pathway is our greatest kind of opportunity. Some good work in terms of the hearing pathways have already been done there. We're really successfully using our ENT forum to look at our local commissioning policies. So we've done some work around our adenoids and grommets, and some work to do around tonsillectomy in the coming quarter. We've done a lot of work with audiology in terms of standardising referral forms into our complex audiology service, which will in time stem some of that flow into ENT. So looking at things like direct listing for MRI from audiology in the cases of unilateral hearing loss and tinnitus. And there's some brilliant work going on at Worcester around the recruitment of an ENT ACP that will help facilitate some of that work, and who's potentially also looking at direct listing for grommets as well, which will reduce some of that ENT demand. We have also been exploring our options in terms of supporting ENT through patient choice as well, but being really, really clear on where that support is going to be most effective for us when we've got this high demand and long wait at the moment. So I think I've covered off most of the areas there. If there are any questions, and safe, Steve, please come in.
Yeah, could I ask Amy, that's great, and that's some great work. Firstly, I see on the right-hand side what's next. Complete accommodations Q3 25-26. That needs to be brought forward, I would suggest, because we need it ASAP. Secondly, can I just talk about EBIs, things like septoplasty and conditions such as that, about the criteria for referral, what have you? Where are you on EBIs? And did you get the document that I sent round that was based on Cheshire Merseys, which I thought was the best one out there? We've got all the data now on Model Health System on the top 20. Where are we on that?
So the EBI work comes through into the policy review as well, so it's embedded as part of that. But I think we could have a greater focus on it. We're kind of looking at it as policies come up for review rather than proactively taking that forward. So that's good.
Yeah, so Amy, can we ask again, proactive, please? I think it's important. Why? Because we're going into 25-26. We know it's going to be tight. Therefore, we do not want to spend our time using our assets operating on the wrong patients. We need to make sure we operate on the right patients, get the best results, please.
Yeah.
Thank you.
Thank you for that. Safe.
So having been through the GIRFT leads Safe ENT consultant Hereford, I think one of the major challenges we have is our outpatient capacity, and what I've seen is a creeping increased waiting list and 52 and 62 waiters, and at the moment I think this is where we can make the biggest gains if we are able to increase our outpatient capacity through staff and rooms. So currently one of the major challenges is most of our rooms are being used, and we are looking at a fourth room that we have installed, but it's a little bit small for potentially performing a routine clinic. But these are where we should just concentrate on if we were to meet the targets that we've looked at.
Dave, can I ask how many patients you and your colleagues see in a 4-hour session routinely?
12.
And
oh, sorry, 11. Sorry.
Okay,
11.
Is that across the specialties, or do audiology or the nose docs do less? Where does that all sit?
No, it's pretty much across the board, apart from specialized clinics. Whereas if there's a grommet list clinic, then the patients will have half-hour slots, or a complex clinic run once every 3 months jointly between 2 consultants. So that's but the rest of the clinics are pretty much the same.
Okay, thank you.
You're welcome.
Okay. Are there any other questions to the ENT team?
Nope.
Fiona.
Yeah, Amy, hi, good to see you. If you need any support from the regional team, Rupin, our anaesthetic lead, and Matthew, ENT, around those paediatric day case rates, I know we've met with the team a number of times over the last few years, and we don't seem to see a huge increase in those numbers. And I know there's some hesitancy around the OSA, and so please lean on us if you want our support.
Thank you, Fee. That's great. I'll be in touch.
Thank you.
Could I follow up on that? So about 20% of our referral base comes from Mid Wales, which are mostly more than about an hour and more drive. So having a pediatric tonsillectomy, our guidelines, national guidelines, will tell us to admit them if they're more than 45 minutes drive away. So those are the patients that are being admitted mostly. And because we're doing smaller numbers, so about 8 to 10 per month, it takes 1 to 2 to skew the figures, and therefore you'll see a lot of skew and variation month by month. So just to clarify that. Thanks.
Thank you, Saif. I mean, it's something that we talk about every month at the forum. Okay, I'm going to allow the couple of comments, but we do need to move on. But can you go in, Fiona?
Katie, I think you're probably going to say what I'm going to say, so I'll let you come in and yeah, you can have the stage for a bit.
Sorry, Katie, you're muted.
Yeah, sorry, and it's worth looking into a little bit more, but I think the guidance is actually it's 45 minutes from an acute provider rather than the host provider for emergency care. So it might just be worth looking into that as well.
Yeah, although I've got to say, if you're bleeding from your tonsils, you don't want to go somewhere where they haven't got an ENT specialist. But let's.
No, that's what I mean. A compute provider that can manage it. That's what I mean. It doesn't have to be the host acute provider. And I was just saying it might make a difference. I don't know from your geography.
We'll look at the geographical spread on that and where the acutes are. Wonderful, thank you, Amy. Thank you, team from ENT. And we're moving on straight away to Kelly, who's one of our newest recruits from an ophthalmology point of view, and so it's a little bit going to be. The first task you've had with arriving is to get ready for this meeting, really. But Kelly, and we've also got Tom and George for the ophthalmology teams.
Angus, I'd just like to say Tom Jackson couldn't join us today, so we've got Mr. George Morphus from Wye Valley and Directorate Manager Zakir Galeb from Worcestershire.
Okay, so in the interest of time, Kelly, if we can just try and go through the slides relatively quickly and take from there.
Okay, so starting with our waiting list, it's been steadily decreasing since May. Our data shows that it reduced by 11.6% between May and September 24. Unfortunately, we didn't achieve our target of 0-65-week wait by December, but we're now working towards the end of March. As of January 16th, 11 patients have been waiting over 65 weeks. All are now booked in before the end of the year, and there were 425 patients in the 52-week cohort. Trusts have plans in place to reduce these waits, meeting weekly with the ICB to review progress and unblock challenges. Corneal transplants have been a particularly challenged area for both trusts due to surgical capacity and tissue release criteria, leading to 78-week waiters in recent months. These long waits have now been resolved, and we're collaborating with the regional team to tackle ongoing challenges for 65 and 52 through mutual aid and joint working. Moving on to the further faster initiatives. Looking at Wye Valley first, in December they removed 200 patients from the waiting list, with over half of those already treated elsewhere. They don't use the PIFU pathway and instead discharge patients back to optometrists, so we're not expecting to see any increase in PIFU rates. Their DNA rate is currently 8%, and in December they trialled proactively contacting patients to try and bring that down further. We're still waiting on the results of that, so it will be interesting to see what impact it's had. Over at Worcestershire Acute, they're taking a proactive approach to validation, checking patients around the 40-week mark, and they also have got a quick turnaround for 48 hours for advice and guidance. Their ANG numbers are quite low, around 5 or 6 per week. Implementation of EERS has improved communication between the acutes, optometrists and ISPs, and has also improved triage management as referrals are picked up directly by the subspecialty teams now. They're performing well compared to other trusts in the region, with a 3% PIFU rate, placing them in the upper quartile nationally. For DNA rates, they're in the top 25% nationally at 6%. This success is due to screening general anaesthetic patients 3 days before surgery and implementing a standby list for day cases to fill last-minute slots. And in line with the right procedure, right place approach, Wye Valley established their cataract hub last July, which has led to an increase in the number of day cases. Next slide, please. Looking at the data as of January 12th, we're outperforming our peers when it comes to cases per 4-hour session and theatre utilisation. On average, we're doing 4.2 cases per 4-hour session, which puts us at the top of the rankings in the West Midlands. Our capped theatre utilisation is sitting at 77.2, with Worcestershire just ahead at 80.1, ranking second in the region. That said, we've noticed that theatre utilisation can fluctuate quite a lot, and it's not always as good as it could be. So one of our key priorities for 25-26 will be improving theatre efficiency and levelling up. That includes tackling late starts and early finishes to make sure we're getting the most out of our available capacity. Next slide, please. In October, our day case and outpatient performance was at 99.4, putting us ahead of the peer average. For cataracts specifically, our day case rate as a system increased by 0.5% from the previous month, reaching 99.6, just shy of the 100% benchmark. A big driver behind this improvement has been the implementation of the cataract hub at Wye Valley. Since June, day case numbers have more than doubled, going from 361 in June to 790 in October. Looking at cataract numbers per list, in December, I know we had some numbers earlier, but this was looking at December, Wye Valley was averaging 6.7 cataracts. That's number of cataracts in this instance, not cases, since 20% of their cases are bilateral, and that trend is increasing. So current waiting lists show that bilateral cases now make up around 40% of their cases. At Worcestershire Acute, the December average was 7 cataract cases per list, with training lists averaging 6. The majority of surgeons are achieving 8 per list, but the few that aren't are bringing down the overall average. And it's important to note here, highlight here, that trusts are facing challenges in consistently hitting the recommended standard of 8 to 10 cases per list. Key reason being that simpler cases are being diverted to the ISPs, leaving trusts to handle more complex cases, which, along with increasing number of bilateral procedures, takes up more time. So we'll be looking at ways to increase throughput for simpler cases.
Just on that point, I think Tim wanted to come in. I was not surprised to see his hand flash up.
Yeah, so Kelly, the numbers on a list are not where I need them to be, all right? Given how much you're losing to the independent section, I would imagine that the consultants who do work in the independent sector do 10 or even more than 10 on a 4-hour list, it seems to be. Everybody else does elsewhere. And if you go to Nottingham, on all complexity cataracts, they do a minimum of 8. So I understand complexity, but I don't. And I assume they're all under local, or the vast majority under local. The anaesthetist is not in the room, but that needs to rise significantly. It should be 8 on a training list and 10 on a non-training list. And that is not just my recommendations, that's the recommended by the Royal College of Ophthalmologists. And again, we need to get that work back, all right? So we need a step change in that. I thought someone might come in. Georgios.
Thank you. Yes. So just to complement what Kelly was mentioning is that the recruitment has always been an issue historically with us. So just prior to the opening of the hub last year in May, we were struggling to appoint a cataract high volume surgeon, which we didn't. Now it's more hopeful. So potentially we will be appointing some locum doctors. And over the past few months, we have been relying mainly on middle grades or even other locum doctors to fully utilize the hub, which they are. But obviously, they're not as quick as like a substantive cataract surgeon that we're aiming to appoint.
So Georgios, two things to that. I went to Moorfields. I saw the registrar do 10 cataracts and he'd finished by 12 o'clock. So I don't accept that. And secondly, when people say we're going to find high volume cataract consultants, all the ophthalmologists I speak to who are not high volume manage to do high volume in the independent sector. So again, just taking it, we need to reproduce what we're doing in the independent sector in the NHS. That's all I ask. And it's 8 on a training list, 10 on a non-training list, and we should be able to do that. I've seen lots of ophthalmologists who are not high volume do 8 and 10 a list.
Yeah, so please bear in mind though that we have actually registrars ST1s, ST2, ST3s. So there's no way an ST1 starting in August, very first job.
Yeah, get that.
That much high volume.
I get that.
We need to train them.
Yeah, I get that. But the numbers.
But we're getting there. Yeah.
But we need to get there a bit faster, Georgios.
Absolutely.
Okay. Carrying on.
The final point I was going to make on the previous slide is that we will be looking at prioritising, looking at ways to increase the throughput for simpler cases. And one of the things we're going to be exploring is the single point of access for better management of cataract referrals. So on this slide, when we look at emergency readmission rates following cataract surgery with a 0-day length of stay, we're performing well at 0.3, which is very close to the national benchmark of 0.2%. That puts us in the top 3 nationally. For readmissions where the stay is 1 day or more, our system value is 1.3% compared to the national benchmark of 1. Despite this, we're still ranking 3rd regionally, showing strong performance overall. Next slide, please. So far, we've seen some good progress. A big win has been the implementation of the Cataract Hub at Wye Valley, which has directly contributed to day case surgeries doubling. Another success is the rollout of EERS in Worcestershire, with 88% of optometrists already signed up, along with all but one ISP. This has been a game changer, giving us oversight of referral pathways, amongst other things. And once fully embedded, we'll be monitoring referral patterns and trends to better understand patient flow and whether choice is being appropriately offered. Referrals through EERS continue to increase every month, as you can see here. And over the next quarter, we expect all signed up optometrists to be fully utilising it. We've had really positive feedback from both trusts and ISPs and optoms on the benefits of EERS, including supporting patient choice, improving communication between referrers and providers, enabling easy transfer of photos and scans, and providing the trust and ICB with accurate referral data. And finally, another significant achievement is the cataract waiting times at Worcestershire Acute. We've seen a huge reduction there, dropping from 23 weeks in January 24 to just 6 weeks now. So what's next? To sustain the progress made and tackle ongoing challenges, we're developing a comprehensive system-level programme plan for ophthalmology, one that aligns with national guidance, and we'll be establishing an ICS ophthalmology steering group to drive delivery throughout 25, 26 and beyond. Initial key focus areas will be exploring options for the single point of access to support patient choice, continuing the rollout of EERS across Worcestershire and Herefordshire, ensuring full system coverage, and driving efficiency and productivity improvements within pathways and theatre utilisation. So there's been good progress so far, and with these next steps, I think we're in a strong position to build on that.
Yeah, Kelly, I'm delighted with that. And so you've got a waiting time at 6 weeks at Worcester Acute. What is it, Wye Valley? The waiting time for HCLC cataract?
I'm unsure of that. Can colleagues on the call answer that question?
Georgios, do you know?
So you mean waiting time from referral to treatment?
Yeah.
No, that's long. That's 40+ weeks.
Okay, so that's why no one's coming to see you, Georgios. So what I want you to do, Kelly, is this. So I want you to get the HVLC cataract as a separate waiting list that we've done down in Devon, Hampshire, Isle of Wight. You've got to get to the sweet spot of less than 10 weeks of referral to treatment, okay? And single point of access, you don't need to assess options. There's 2 options you can either use. That's a individual person giving the advice to patients, and that's Devon, the ICB at Devon. So John Finn is your person to speak to there. Or you can use Dora, which is working very well in Hampshire, Isle of Wight. And by doing that, their referral time, the patients that want to use the NHS is 72%. That's how we're going to do it. So single point of access. So in Q1, I want you to explore Devon and Hampshire, Isle of Wight. I want you to decide which one you want to do, and I want you to implement it across the ICB, and at the same time work with Y Valley to get their wait down to 10 weeks, and it can be done. And Devon have done that. They went for a year to 10 weeks. Hampshire, Isle of Wight are now 8 weeks and 10 weeks. So if Worcester Acute can do it, and now at Y Valley you've got the surgical hub, there's no reason you can't do it there. And I want to see implementation of a single point of access, which will make a massive difference to the patients that want to come and see you. All right. Thank you.
Okay. Thank you, Tim. Thank you, Kelly, for that, and Georgios for your input. We've got 20 minutes left, and we've got 3 presentations still to go. So really putting this to time, Jamie. Jamie, Deo and Mr. Bandy are here for the general surgery side of things.
Thank you, Angus. I'll lead off in the first instance. I'm sure the clinical leads will come in as required. So starting with waiting times, you'll see from the graph on the right, we've made reductions in the number of patients waiting, albeit with some fluctuation around March, April 24. We are on that downward trend of seeing reductions there. Similarly for our 52-week wait, going from 740 down to around 120 for the end of Q2 24-25. Part of that is due to referrals, seeing a reduction in referrals due to the implementation of the FIT pathway at Wyre Valley. The FIT pathway has previously been implemented in Worcester as well. Moving on to outpatients, our PIFU, you can see from the graph has steadily increased, although still below sort of the system median of 2%, and obviously below that national position. Although we do believe that our sort of discharge rates remain strong within general surgery, albeit maybe some more work to do for PIFU. Similarly for advice and guidance, we're below the national sort of rate at 5%. We have been working with James Ecclesley, the regional GIRFT lead for general surgery, to look at some best practice throughout the region there. Missed appointments, one of the top performing systems here with a DNA rate of 3.8% in November. Next slide, please. Moving on to theatre productivity and utilisation. Our average number of cases per 4-hour session is in line with the national benchmark at the end of Q2 at 1.7, with our theatre utilisation as a system at 85.5% for the end of November, against that provider median of 82.3%. And you'll see in the graph on the right there the 2 trusts with Y Valley just under 90% and Worcester just over 83%. Looking at some of our procedures for length of stay. So length of stay for less than 2-day rate for emergency appendectomy, we're at 28.6%, which is below the national benchmark, but we are above the peer benchmark there of 22.8%. And looking at the median length of stay for emergency laparotomy, we're at 11.5 there, again, which is below benchmark, but is in quartile 2. Next slide, please. And some of the areas where we're performing against national and peer medians. So some of the areas there focus on, as already mentioned, looking at specialist advice, how we can further improve PIFU. Another area we have been looking at is our emergency readmission rate. So looking at particularly some of the coding around our readmissions there, particularly some work done at Wyre Valley. We've broken that down to a monthly metric rather than the 12 months to quarter end, and we have seen some improvements there, so we're hoping over time that will improve as well. Next slide, please. And finally, just capturing some of our successes to date. So as a system, we've started to develop and implement a pelvic floor pathway. So I think there is more work to do there, but we've seen some positive results, particularly Wyre Valley holding some joint clinics there between the pelvic floor team and physio. Wyre Valley have very recently moved to ERS direct bookable, so that's really positive. And as I said earlier, the implementation of the fit pathway on both sites. Again, I've touched on some of our work for the future around sort of readmissions, advice and guidance, and further developing that pelvic floor pathway as well. I don't know if any of the clinical leads wanted to come in at that point to add anything.
Anything from Dale or Steve? Any questions, Tim? No, that's fine. Dale?
Oh, sorry. I thought I was going to talk about. I was just going to mention about the about the readmission rates, but that's already been answered because that was due to kind of coding errors from STEC.
No problem. Well, thank you very much indeed, and thank you for being to time on that, Jamie. I appreciate it. Moving on to urology now. Anita is here, but we've also got Mahmood Akhtar, Vincent Koo, and also I think Christian Nair is here as well. Let's start off, Anita.
Yeah, of course. Thank you, Angus. Yes, in terms of, obviously, we've had the Urology Specialty Forum in place now for quite some time, and I think safe to say that we've been on a journey in terms of as a collective to kind of move some of the kind of dials on some of the areas that we've been looking at. So just in terms of the current performance against our waiting times, you can see there we've kind of seen a reduction followed by a slight increase, but also a reduction since September 2023 of almost half of the waiting list of patients waiting over 52 weeks. Across the Further Faster outpatient transformation programme, we've seen some progress around PIFU. I think there's further work to do there, and I think there's an acknowledgement on that one. But also in terms of we've been really kind of having an active discussion around the discharge rate as well within the trust, so we want to kind of align those two metrics in order to make sure that we're optimising both of those options and we're not just PIFUing patients for the sake of it when we can actually discharge them. Then also in terms of the remote consultations, they continue to perform well in terms of utilisation of that as an option for patients with it's currently rated as a mid to high quartile for those at 28.2%. In terms of the right procedure, right place, obviously we've had some really good kind of statistics around the day case rate. You can see there in terms of 89.6, and we've also had the development in terms of some of the diagnostic programs as well around the development of the simple flow studies, one-stop clinics across all 3 sites in Worcestershire, which has significantly reduced the amount of the current waits for urodynamics. So we were up until about last month reporting 0, but the numbers are really small in terms of those patients waiting over 6 weeks. And then also we've had the development around the robots across both counties in terms of improving local access. So we've been able to repatriate a lot of the activity that was previously going to Wolverhampton with considerable waits, and also our ongoing reliance on Northampton. Next slide, please. In terms of theatre utilisation and productivity, you can see we do really well in terms of a lot of the day case areas that we've got there and performing above the peer and national median. There are some improvements that need to be noted as well in terms of 2 specific areas around the male bladder outflow surgery, where you can see we've seen some improvements. There's further kind of improvements that we can make on those 2 areas, though, on ureteroscopy. And then in terms of the length of stay, we've seen some significant reductions there as well in terms of across the procedures. We have got some length of stays that are higher in some procedures, as you can see there, they're listed, but they are representing an improvement in terms of going in the right direction. Next slide, please. just a couple of areas where we are performing well, and also the areas that we've got in red, where we currently don't benchmark higher than our national or our peer group. And those are the areas that obviously we'll be looking at focusing on specifically as we move into 25-26. And then finally, just a summary slide in terms of some of the success of work to date. Now, I have to say, in terms of the collaboration between the two sites has been really, really good. We've now got active conversations going on around mutual aid for things like robotic prostatectomy and cystoscopy, which has really helped out in terms of some of the pressures at either system. So we're not having one part of the system reducing their performance whilst the other just carries on. And we've also had some really good collaboration across the two trusts, particularly around things like the video clinics, the pelvic floor MDT across the system, the stone MDT, etc. So you can see it all listed there. Two big developments over at Worcester Acute in terms of the implementation of the urology UIU that went fully live in October. I think it went live before that in July, and also the nurse-led prostate biopsy service and follow-up clinics at Worcester as part of that. And then you've got the developments that we've seen in Wye Valley, which was around the Reasum Hull-up service that started in January with a view to moving that to day case in 25, and then the portfolio pathway in terms of that's been in place since 2024, and we've had the first of 2 candidates recruited to that. And then we've got the hot ureteroscopy service that's been developed, which has reduced the requirement for second admissions. Lots to go out in terms of for next year, so you can see the list of some of the things that we're going to be looking at. So it's the standardisation of PSA pathways across the system, continued focus on outpatient productivity and transformation, and making sure we're utilising PIFU and remote consultations, etc., as much as possible. Resolving the reattends and readmissions coding issue, because I think that's kind of skewing some of the figures that we've got, but also looking at opportunities around development of a system-wide service as well across the sacral nerve stimulation, which is one of the things which Christian is on the call for and is leading that. And then also there is some early discussions around the development of a business case for a second UIU at Kidderminster Treatment Centre, although there is a focus for 25-26 in relation to recruitment, so that we're in a really good position to enable to support that. And obviously we'll be looking at urology as one of those 5 specialties that were identified within the Reforming Elective Care for Patients documentation that came out recently, and some of the opportunities around that as well. So that's the plan for next year. I don't know whether Vincent or Mahmood want to come in with any additional comments.
We see that thank you very much indeed, Anita, and I completely concur with your, the collaboration between the two teams is working really, really well. Tim?
Yeah, so I was going to say that, Anita, that's the most joined up presentation I've seen of today in terms of everybody working well together. And Angus, that's what we need to do with all the other specialties. Just one question, Anita. When you look at the data, the day rate for TURBT is good across both sites, and yet when you look at day case uteroscopy, it's not where it should be. Why is that? I don't understand why that is.
I'm glad you've come in, Mahmood.
Professor, actually, we used to have the evening list, but you will see a significant change in the next year, because now we have abolished the evening list and we are doing a morning and afternoon list, and hopefully the next coming data will improve that. Also, we have implemented the hot ureteroscopy list, so no patients is going home and getting the primary ureteroscopy. That rate will improve also in the next year. We will certainly keep working on that.
Okay, thank you.
Wonderful. I think that Christian was going to say the same thing. Wonderful. Thank you to the urology team. Appreciate it. It's okay with Tim. We'll move on to one very busy slide, but only one slide. And Chris, I think you and Sarah are going to talk to this. This is around urgent care, innovative approaches to patient flow.
Yeah, it's thanks, Angus. It'd be myself today. So a range of interventions detailed across the page. And I think if we look at some of the, conscious of time, some of the headline implications. So in terms of our CAT2 responsiveness, we've improved that by 7 minutes in year. Length of stay has continued on a downward trajectory at Wye Valley. Worcester, there is still some more work to be done. Our EAS performance, Wye Valley have maintained their gradual improvements throughout the year. Worcestershire, we are only starting to see some improvements in that in the last 3 weeks. Still need to focus on time of patients in the department. That's still quite static at 14% in Wye Valley and 21% in Worcestershire. I think it's fair to say that the benefits from a Worcestershire perspective have started to be seen in the last 3 to 4 weeks, a real shifting of the dial in terms of many of the metrics, a slashing of 180 minutes for specialty referrals to ED has really helped in terms of get some of that intra-hospital flow. So lots of interventions. We are discharging record numbers of patients. Now need that to become a consistent theme and translate into improvements in some of the other key UEC metrics. Angus, try to keep that brief for you, conscious of time.
Thank you very much indeed. I don't know, Tim, are there any questions about the urgent care aspects of things?
No, the only thing I'd say is the 45-minute handover, I think it's critical, Chris. We've done some really good work in Nottingham over that. And I think their Cat 2 is reduced by 18 minutes. And the number of ambulances that were stuck on site, the number of hours saved, I've forgotten the number, it's massive. So that, I think, is a really important thing to do.
Absolutely, Tim. And just want to reference some really latest data. This has not been as a result that it's been quiet or etc. Wye Valley is doing routinely plus 80% in that category and improving. Yesterday, and colleagues will be delighted to hear this, Worcestershire had the best handover performance in the region, 100% in 45 minutes, only 3 lost paramedic hours. So we've shown as a result of some of these actions, some of the improvements we can make, but absolutely take that on board.
Wonderful. Thank you for that, Chris. I mean, there's lots that we've gone through, Tim. I'm sure there are, this is not limited to these things, but we've mentioned outpatient templates. We've mentioned the return of independent sector work into the acutes. We've talked about the short stay in orthopedics and the focus that needs to be on that. Common conditions in ENT. We've talked about the importance of ophthalmology, again, to do with the private sector, but also looking at the single point of access. There's lots for us to take away. Comments from you, questions to the whole panel if you want to ask.
No, I think that you're doing some really good stuff, Angus. There's no doubt about that. And if you look at your metrics between Wye Valley and Worcester Acute, there's really good elements within those metrics. Just got to share them. I get the impression that you're still 2 very separate trusts, except for urology, where I thought there was really good evidence of you've come together really well. And I'd like to see that a bit more. I think you're very lucky that you've got your hubs, and I think we need to really maximise those. And I would say in orthopaedics, reducing your length of stay, maximising 6 days a week, but also your cataracts. You cannot have 6-week wait on one site at Worcester Acute and then Wye Valley 40 weeks. I'd stop Wye Valley doing them and I'll move them all to Worcester Acute. I think that is where we're coming to. That's a huge health inequality, and patients want to come and use the NHS if we give them a reasonable time frame. So single point of access and then getting those times down. But no, it's just the pace at which we do things. And I like your ambition, what you think about Q1, Q2 of next year. We've got to be much quicker than that. We've got to start implementing these things going forward. And we're here to help and support, as is the regional GIRFT team. We want everybody to be successful. And if we're going to win in this, and I'm passionate about the NHS, we have got to do as much of the work in the NHS as we can, and using the independent sector for some of the work, but the vast majority has to be done in-house. It's been an easy safety valve in the past, but there's going to be a lot more, I think, vision on what we do and how we use our assets going forward. Because what we cannot do is pay people to not do the work in theatres or what have you, and then we double pay in the independent sector. So you're doing a lot of really good stuff. Build on it. Let's see you working really well together. Learn from each other, but let's really drive it. But no, there's a lot of really good stuff.
Thank you for that. And yeah, that message is clear and I think shared by many on the panel. Mary.
Just want to say thank you, Tim, and to all the GIRFT team. And when you see all this together, it shows the power of this programme, doesn't it? And I think it's one of those programmes in the NHS that, we have so many different ways of changing things. This really works on the ground. And I think we just need to build this into all of our other work as well. But thank you for the support. It's really welcomed.
We love helping. Great.
Thank you to everybody.
You chaired it well. You chaired it well.
We just got there. Okay, thanks everybody for joining, and have a good day. Take care.
Good to see you all.
Thank you all. Goodbye.